Hello and welcome to MIT Sloan Alumni Online. Every month, MIT Sloan Alumni Online brings you the latest breaking news, cutting-edge research, groundbreaking ideas, and school updates from MIT Sloan faculty, alumni, and students. Today, we're thrilled to have Ayesha Khalid joining us. Ayesha is the Clinical Director at the Yale Center for Biomedical Innovation and Technology, CBIT. She is a practicing surgeon and clinical instructor at Harvard Medical School with 15 years of experience in the healthcare industry. As an ear, nose, and throat surgeon, Ayesha pioneered groundbreaking research in sinus inflammation and clinical outcomes in sinus disease. She received her MBA from Sloan in 2014 through the Sloan Fellows Program, focusing on global leadership and innovation. Ayesha has combined her medical expertise and innovation experience to apply a systems thinking approach to solving healthcare problems. As a practicing surgeon, Ayesha understands the healthcare change process and the need to foster cross-disciplinary engagement. She is currently co-teaching healthcare and life sciences ventures at the Yale School of Management, as well as medical software design at the Yale School of Engineering and Applied Science. In addition to hearing Ayesha speak today, we encourage you to view her TEDx talk entitled, Why We Can't Fix Our Healthcare System. Ayesha, we are so happy to have you here with us today. Thank you for joining us. I'll now turn it over to you.
Hi, Betsy. Thank you so much. This is excellent. Can you guys hear me?
Yes, you sound great.
Oh,
welcome.
Perfect. Okay, so first of all, I am pretty sure there's folks in the audience that'll have some great insights into this, so thank you so much for having me. And as a Sloan alum, this is a real honor to be doing this. And what I'm going to do is I'm going to walk us through a little bit about digital health, what the current trends are, what's happening, but really this is intended to be more of a conversation and really thinking about what the questions folks have around what's coming, really understanding like how we're going to blend things like value-based care with digital apps, and really finally ending with the patient perspective and what patients are looking for and why it's so important that the dynamic nature of digital health is really going to allow for bending the cost curve. So, let's get started. Next slide, please. So this is one of my favorite quotes. There's a lot of quotes by Einstein that I love. And this one is the same one that I used in my previous TED Talk. And, we just sort of seem to do the same thing in healthcare. So healthcare is one of the fields that is slowest to adopt technologic change. And it was very interesting being at Sloan and finding out that in so many other industries, from an operational point of view, when things don't work, we really break it down into its parts and really think about how to do it differently. So even in the operating room, the way in which we book cases and think about time management and operational efficiency hasn't really changed in a number of years in most hospitals. But there are tools, electronic and otherwise, that we could really utilize. So we'll get into that a little bit and sort of what that feels like for the patient. Next slide. I think it's important to bear in the back of your mind that, when patients come in, there's such a limited time window that they have to tell you what's wrong with them. And so there's some great research out of Hopkins that really tries to talk about the fact that the patient journey starts from when they first feel that they need to see a healthcare provider, not even necessarily when they come to see you. And the first thing that happens now for a lot of our patients is they are on Google and they put in the constellation of symptoms, and they might even start feeling and believing and be right that they have a certain disease. But more importantly, they might be wrong. And so what happens is when they come in, they're presenting you a picture, and you sort of have to tease out what's related, what's not related. Everything stems from that. And it's really key to think about digital health from this perspective, because the only data it used to be that patients could bring you would be historic data. On Tuesday, I ate peanuts. I felt I had an allergic reaction. I'm guessing I'm probably allergic to peanuts, but I do eat peanut butter or peanuts every week. And I eat a whole host of other things as well. And so there's no tracking around that. And so when you start talking to patients, they have to try to remember how they sleep, or when their pain first started, or, was their blood pressure always high, or are they just anxious right now with a life situation? What digital health does and should do in the future is really help us to track the dynamic part, so that when you come in to see a physician for what I consider a static short visit, you're able to show some information before, during, and after that is well synthesized, easy for me to not to have take too much time out of my day, And if over the course of a minute I can get a much better understanding of your snoring and your sleep apnea, I'll actually be able to decide whether or not you need the sleep study or whether there's a different problem that's going on. And that sort of data capture, either through pictures, sound, and a synthesis of your sleep pattern, as is present in a lot of apps now, and I think will continue to improve, is really invaluable in the diagnostic process. 15% is the current rate of diagnostic error through the patient journey. My guess is it could even be a lot higher. People spend 5 to 7 years getting an accurate diagnosis with a rare disease, and it's not that physicians or patients don't want to figure it out. It's just that the data isn't there, like right at the outset. So we'll talk a little bit more, but I wanted to set the stage with that. Next slide. The other thing to note, and I'm using this very, very common slide that we use through all the presentations for MIT Hacking Medicine, which is a great group I've been involved with. But essentially, I feel like we're at this gap, right? There's always a shift in healthcare, and particularly recently, we've had a lot of conversations around how healthcare is going to change yet again. And that being said, the question becomes that, what opportunities exist for you, for folks from Sloan, in terms of filling that gap? Well, I can tell you that it's probably a really great time to be engaged in healthcare innovation. And digital health and health IT present sort of a unique opportunity because there's skill sets that we don't normally get trained in within healthcare. And healthcare can be very intimidating to break into. So we'll talk about that a little bit as well, particularly the incentives that are involved. Next slide. So where's the leverage in the system? This system it's sort of a joke that every arrow leads everywhere, but the reality is the leverage point really is the fact that the better information the patient can present, the better information that the clinician or the insurer has, the better care that's going to be given. And by better care, it means the better outcome. And in order to get to that, the last slide was intended to demonstrate that one of the beauties of digital health is that you can actually do some iterations to your product. You can actually do iterations to the patient journey relatively inexpensively. It used to be that the majority of innovation was medical device or hardware or pharma. And what happens there is those are very expensive. So on the one hand, it's less expensive to be engaged in digital health in some ways. But then the question becomes, is it working? Is it trusted? And does it actually improve outcomes? Next slide. So I think this is a really common cycle for MIT and for Sloan where, the test and learning is the thing that's really different in this process. I think before I came to Sloan, we did a lot of teaching, and you would do a lot of learning by watching, practicing, and then, doing surgery. I think the stakes in that situation are really high. I think the important thing here is in order to get value out of some of these apps and device plus app algorithms we'll talk about, you're able to do that a lot simpler because you're able to change and iterate. I think most digital health tools, everything I've said so far has been really positive, but the reality is most don't deliver because they tend to either observe or just pitch. So by observe, they tend to track your data. They track sleep, or they track your fitness, or they track your steps, and they put that into some sort of area where they feel like, that is there and happening, but they're not doing anything with that. So that being said, how can this be different? Well, the way it can be different is you have to also test and learn. So what you really have to do is you have to be able to say, look, we're going to track the data. We're going to see how the patient does. And then I'll go back and see if it works. And if it works, I'll go ahead and do it again. So that being said, let's go to the next slide and we'll talk a little bit about. So the prediction of how quickly that's going to occur is pretty difficult to tell, but I can tell you that the velocity and the speed by which this is going to proceed is going to be pretty quick. And the reason for that is because it's almost imperative that hospitals, clinicians, and healthcare systems are having a really tough time. And in order to deal with this tough time, it's kind of the right time for healthcare innovation to be happening. So that being said, we used to be that we didn't think that it was possible to do it quickly, but now we know that it's not only possible to do it quickly, but there is larger and larger sums of money and investment that are going into digital health, more than into anything else. In fact, health IT and digital health have been large areas of investment from angels, from early stage, and from VC. And it's confusing, actually, to some of the larger companies because it's difficult to figure out the business model. And we'll talk about that as well. Next slide. So the other thing to think about from the clinical perspective, for those of you that are, that are listening in, and thank you for listening in, and are really thinking about, but like, why does it matter? I mean, typically people go in, they still trust. A lot of times they trust their doctor, they trust their clinical provider, they still need that. Well, the reality is they might come to see me, but even somebody with breast cancer, or as you can see on this slide, asthma, cardiovascular disease, everyone's motivated at the time of illness or illness discovery, but the drop-off in compliance has been a real difficult point. Nobody wants to be sick. And after 3 months, if you look at the bottom blue line, the rate of people using their asthma inhaler is incredibly low. So, enter something like recently they've had Gecko Cap, and the reality is any of these companies that are trying to track the inhaler usage, if I'm a mom and I have a sick child who's at school, and I'm noticing that, even though the nurse and my son says that they're not really that sick, the fact that they're spraying pretty often, and that data is being uploaded to me and maybe to the pediatrician, when we go in for our next visit, that becomes a really good conversation, a conversation centered around, you say your kid's asthma is okay, but look, let's look at the data. In the last 3 months, in the fall, the usage has been really high. Maybe that's related to allergies or pollen, and we need to do allergy testing. Or maybe that's related to a new pet in the home that's sleeping in the bed of the child. Again, remember what I said at the beginning, historic data is that people tend to remember when they're doing really well and when they're doing really poorly, but it's that in between that's really hard to gauge. And suddenly having the tracker on the inhaler really helps to gauge that. And the morbidity and mortality from asthma that is saved, in other words, the number of times a kiddo has to go to the hospital, and to be honest, in this country, it's a travesty, but we have a number of children die every year from an asthma attack. That just shouldn't happen. I mean, we definitely have all the tools and resources, and schools are becoming very attuned, but I just see that, like, any of these tools could sort of help us on that process to really have that data up front and be in a partnership with the patients. Next slide. So, the next two are just, they're obvious and I love them. And again, like the hacking medicine community, like we show these all the time. So digital health, everyone, feels like the promise of better, cheaper, faster. But the reality is that's not as important. So let's do the next slide. The reality is that we need to trust, and the patient and the consumer needs to trust the tool. And it can't just be faster, it has to be convenient and have the capacity for the data and map along the patient journey. So in order to do that, I guess the question becomes like, how does the consumer or the patient get introduced to it? And it may be through a mommy's group on Facebook, or it may be through your physician, or it may be that, you're a fitness enthusiast and you're looking for it. But the reality is when you do it in concert, when you're designing digital health tools and they are being used in concert with the people that are providing you healthcare, you tend to have a higher level of trust as a patient to feel like, okay, this might be something that isn't just hype, it can be used. That being said, it's actually really difficult to sell digital health tools into either physician groups or health systems. And I think that's where the payers becoming really interested and the insurers in terms of impact at scale will make a difference. And I think health systems at large will make a difference. And we'll address that in one of the spotlight questions in terms of like which organizations around the country are really leading the way in terms of trusted tools that patients and their consumers are totally willing to use. So next slide. So now I'm just going to run through a few brief examples and then we can do questions. So what we really want to do, I mean, this is an old-fashioned doctor's bag. I've never carried one, but there are still physicians that do and nurses that do, and they do home visits. But the reality is, like, next slide, I'll show you what, the tools that we use. So a stethoscope, for example, if you try to design in a way that you think about the engineering, because MIT is all about engineering, this is a very poor tool with very poor acoustics and very old-fashioned instruments that haven't changed, and you're essentially listening to sound. And what's even worse than that is you're trying to place remembering what the patient's heart sounded like the last time that you heard it, and you recorded it somewhere in a patient note. And that just seems like, gosh, that's a lot of things to remember. And yet we've captured a way in medicine to sort of capture that data. And for the most part, it's very accurate, but it's very burdensome and onerous. So is there a better way to do this? So next slide. So there's several companies that exist, but like one of the ones that I think is really interesting because I've tried it is you can put this attachment on your phone through AliveCor, and you can literally have like a pretty good read right up here of your baseline tracing of your EKG. Now, does that mean you're going to pick up nuances of every single abnormality? Not necessarily, but I can tell you that for somebody that has an abnormal fast heart rhythm, it might be nice to just you change medications, and for the next 2 weeks, you're tracking it, and that data is being uploaded. And so change or the delta becomes relevant to the clinician and becomes relevant to the patient. Again, on Tuesday, I felt sick, I felt nauseous, or on Wednesday, I felt like I was going to pass out, and you sort of go back and say, but what did your tracing look like, that day? Try to relate that. That's not easy to do. You have to be able to do it within the visit. So you need some tools that not only have the tracing on the phone, but are able to synthesize that data and then potentially, and this brings up a whole other can of worms, deliver that data, being cognizant of the privacy issue and trying to figure that out as well. So we'll talk about that. Next slide. This is a tool that I use really commonly. Parents come in, the ER physicians use it as well. Does my child have an ear infection, or why is my ear hurting? And you come in and you pay a copay and you sit in the ER. You're looking maybe for antibiotics for your child. You don't want to wait till the morning. You just want to get answered, like, are they screaming because their ear hurts or something else is wrong? And lo and behold, they look in and they say yes or no, and you feel like, okay, that was a really big deal. So is there any better way to do that? Next slide. And so detecting an ear infection, not to get too sciencey on us, but all I want to show with this slide is that there's a visual component to it. There's a movement component to it. So on the bottom right, you see that up-down bell-shaped appearing curve, and that's just what your eardrum looks like when it's moving. And in the middle of this slide, you see something called a tympanometer, which is the usual tool that we use, which, believe it or not, costs like $1,000, maybe $2,000 to sit in an ear, nose, and throat's office to do this test. The thing is, access to an ear, nose, and throat's office is fairly limited. You have, is that the only way that we can figure out if your eardrum moves effectively or looks infected? So along the top, on the left-hand picture is a normal eardrum, and everything to the right of that is different types of infections. If you put all that together, there's so many groups that are working on this, including a few at MIT. But I'll show you on the next slide. The simplest place where they started is a company called SteTHOSCOPE. And I think that at least, if you think about the last slide, at least from the point of view of capturing the visual image, it definitely shows the eardrum as clear, and it looks clear here. And so all you do is you put that attachment to your phone and you look at it, right? And what better optics than your iPhone? I mean, definitely better optics than the tool I showed you earlier. Definitely better lighting, good resolution. You can capture the photo, and then all you have to mark is left or right, and then you can send it off to the company, and they'll actually send it to ENTs. And I have a few friends who will sit and look at it. Now, I don't know that business model will scale, and I can't tell you that this is the right way to do it, and maybe this doesn't capture all of the movement component, but if it answers many moms' questions, at least 1 out of 2, does it keep them out of the ER? I think that is a definite possibility, and that starts to reduce healthcare dollars. And as we talked about in the beginning, it starts to bend that cost curve. Next slide. Reinventing pharmacy. This is one that we talk about a lot as well at Hacking Medicine. And the reason we talk about this one, and just across the board, I think compliance, if you remember, with prescription medication is really poor. What happens here is you really are just miserable waiting at the pharmacy. And then when you do get your pills and you're older, if you look at the photo in the middle, you have to keep track of what you're taking. There's many companies that are working on this problem. But I think the reality is you need something where not only you're aware as the patient, but you have a caregiver. So for example, if my father or my mother or someone else's family is taking something. Like, how do you sort of tie that together and really figure that out? Next slide. And so PillPack is one example, and this started out of a hackathon at MIT. So that's why I brought it up. And really, it's a toilet paper roll, and it just talks about a digital tool that you send the information. You say, I need my refills. Here's my prescriptions that are coming straight from the physician, and it goes through the system. And I won't bore you with the details, but I'll tell you at the other end, it would be really nice for me to have my parents have something where they're taking things systematically now that they require daily medication, rather than the horror of what I hear, which is, well, I wasn't feeling well, so I took, 2 out of 3 pills, and I decided the third one, the pink one, I think it's the thyroid one, I'm not taking. But the problem is we're having a phone conversation, and I can't quite grasp or glimpse which one they're taking or not taking, because none of it's labeled, and they've moved it all into pill boxes, and it's a little bit arbitrary. So how does digital health come into this? It's really a way for the patient to not only keep track of here I am, here's my inventory, here's how I get my scripts over, but it's also a way, to be honest, the most effective help in terms of getting the prescriptions done is often the caregiver, whether it's a child, a spouse, a parent, a significant other. And for them to have the knowledge and to kind of be given permission to go along the journey with the patient would allow me to say, oh, yours are running out. Let me go ahead and refill them, or let me go ahead and figure out which one it was. That's the pink one that is giving you trouble. Next slide. So with that, I'm going to stop. I want to thank you guys for listening. I think we have a ton of questions. I'm going to take those, and then if we have time, I'm happy to offer some additional thoughts. Perfect.
Thank you, Ayesha. I think it's too bad you can't see all of us on the other end, but I think I speak for many people who are dialing in. We're all nodding and relating to so much of what you're saying, and this is incredibly fascinating, so thank you. As a quick reminder, I just want to remind everyone to type in your questions in the Q&A box on the right side of the screen. So go ahead and take a moment to make sure that you've selected all panelists before submitting your question. And then while you're doing that, I'm just going to take a moment and tell you about some of our upcoming MIT Sloan Alumni online events. On September 28th, Professor Thomas Malone will join us to discuss creating more intelligent organizations. Then in October, Christina Chi from the class of 2013 will be speaking about entrepreneurship after MIT, how to utilize your alma mater to succeed. You can register for these virtual events on the MIT Sloan Alumni Online website, or stay tuned for future communications from our team with details. I'd also like to invite you to some of our upcoming in-person events. Please visit our MIT Sloan Alumni Events website for upcoming fall events that may be happening near you. On October 6th, please save the date. We're holding our very first MIT Sloan Global Women's Conference in New York City. Then on November 29th, here on campus, a very relevant conference. We hope you will join us for the MIT Sloan Innovating Health Systems Conference. Programming throughout the day will focus on digital health transformations with industry, academic, and government leaders from around the country. So visit our website to register. Okay, great. So now let's move on to your questions. We'd like to start today with some spotlight questions that were submitted during the registration process. Our very first question for you, Ayesha, comes from Maya Sechkova. She is Sloan Fellows 13, and she's in San Mateo, California. And she asks, what impact would changes in the Affordable Care Act have on the trajectory and speed of implementation of digital health innovations?
Yeah, thank you, Maya, for that question. I think the key is anything that changes the financial paradigm and stresses the system is probably a good thing, only in the sense that we already have a lot of stresses on the system, and we already know that we are not able to sustain healthcare delivery the way that we have it right now. I would love to be able to buy a little bit more meaningful time with the patient. The average number of minutes is anywhere from 7 to 9 minutes that a clinician has. Maybe as a specialist, you can sort of flex it and have a little bit more. So 15 minutes, 30 minutes. The key there is, in order to be able to impact the trajectory of implementation, the incentives have to align. And so they really have to be interested in, okay, what are the ways that we can bend the cost curve? And compliance is a huge one. I think that's the one that's going to have the impact in the digital health innovation.
Okay, great. Thank you. Our next spotlight question is from Elizabeth Haas-Edersheim. She's PhD 79, and she's in Scarsdale, New York. And she asks, what hospitals and other institutions are really leading the learning here?
Oh, sorry. I was muted by accident.
Oh, no problem. I thought maybe we lost you, so glad you're still with us.
Yeah, so I would say the hospitals that are leading, one of the ones that's really leading is the Ochsner Institute. They are really doing a good job. They have something called an app bar where they basically when you walk in, it's pretty cool. It's, I guess right after the, very similar to the app Genius bar at an Apple store. And you walk in and there's just like tools, right? But it's not just that they have the physicality of these iPads with digital health tools. It's that they've really thoughtfully thought through the framework of the few tools for diabetes and cardiovascular disease that they're using, and have really started to make note of that. There's plenty of hospitals in Boston that are doing this as well. Another health system that's taking a little bit of a different approach, which is really interesting, is Jefferson. So the Jefferson Health System is really thinking through and being very thoughtful about making sure that ER is a place where patients get tracked very quickly. And in order to get tracked very quickly, they have instituted quite a bit of apps there as well. And I think that's pretty cool. So, Henry Ford Health System is very forward thinking, and they have really worked hard as well. And they not only have done a great job in their tools and in the digital health that they're using, but they're actually exporting that. So they run a consulting service that says, look, if you want to see flow through and you want to see the measurement of wellness that like they're doing, and Cleveland Clinic is another example, we're happy to sort of share that expertise. But understand that when you are working with hospitals, like that was all positive, right? So I told you all the positive things. There's a lot of hospitals doing things. But let's be honest, hospitals are like monolithic institutions, and super, super difficult to get something in and have it paid for. And, the number of digital health tools that these guys are seeing and then have to decide like if they're going to use is really huge. And that's some of the work that I'm doing at Yale as well, is really evaluating them from like a cost benefit perspective. So I would say then let's look at it the other way. Let's look at it in terms of institutions. I think for the first time, the FDA is starting to think about and has put out a draft guidance for digital health and web-based tools. And I think that's going to be really important from a regulatory perspective. I think that as groups and think tanks and consumer groups become much more invested and interested, and not just consumer groups, but let's be honest, other institutions that have made a big impact in healthcare, CVS, Walgreens, they're running huge volumes of consumers through their digital experience, not only through the shopping, but through the pharmacy experience. And I think those are the places where, for better or for worse, you're going to see a lot of the innovation coming through an area that has really struggled from customer service. So if that's helpful, I think it's across the board. But I do think there are some pearls in those hospitals that I mentioned, which, by the way, may not necessarily be the Harvards, the Stanfords, the Mayos, because it's a lot harder to change mindset at the larger institutions. There's a lot of history of the way that we do things. So in some ways, the smaller community hospitals are almost the best way to go when you want to pilot something.
Okay, great. Thank you. We have a question from Kylie Liu. She's MBA 01, and she's in Menlo Park, California, and she's asking, where do the opportunities lie in the consumer and clinical space?
Yeah, so the consumer and clinical space is huge. I think the largest opportunity lies there. So I think everything in my talk that focused on from an institutional or a provider perspective, I would say that there are plenty of digital tools that are taking hold and really making a difference in mental health and diabetes and sleep. And the business model can be tricky, because if you take the traditional model, it's how many users do you have? Do you do a subscription model? Do you do a freemium model? But even all that aside, I think that once you get something that has user design, which really solves a specific pain point for a patient, and by that I don't mean all medical illness, or for example, I'm not a fan of apps that measure multiple chronic diseases, but let's just take sleep, for instance. If there's a way for you to really not only track sleep, but really synthesize that data and provide it and give feedback with some helpful suggestions to the patient, but also to the clinician, that is something people will pay for. And it starts out cheaply, $1, $5, $10. But if you Google on the health section of the App Store, you'll see that there's some apps that are charging $50 to $100 to really unlock the package and really figure out, what's happening. And we're doing some work now with Ranked Health where we're trying to really put something on that, like put a consumer index on that so that it's helpful for consumers to know, like, is it measuring what it says it's measuring? But once we get into a world where it's regulated, like some of the hardware tools, I would say the consumer space has the biggest opportunity. And if you want to subdivide that, I would say within that, things like heart disease, diabetes, sleep, and mental health definitely represent some big buckets where we still don't have tools, but people do need to track things pretty effectively, if that's helpful.
Okay, great. Thank you. We have a three-part question here from Charles Cutler. He's a Sloan Fellows 89 in South Orange, New Jersey. And his questions are, what are the major capabilities of digital health? What are some critical success factors, and where have the greatest results been obtained today?
You might have to remind me of the parts, but
not a problem.
What was the first part? What are the
So the very first question is, what are the major capabilities of digital health?
Okay. Well, so that's very interesting. First of all, people just lose paper. Like, let's just start there. If you think about the fact that just in the world of seeing a doctor or nurse, you go and they hand you these pieces of paper, which you then throw or lose out or forget or never read. The fact that everybody has a smartphone in their pocket and we stare at it constantly and we seem to be able to do our banking through it or, message friends or look up things, it only makes a natural sense that the capability of having something that has design that fits both on a desktop, but more importantly on a smartphone is huge. Security and capability is an interesting, secondary consideration within that. The reality is that we're never going to be so secure that nothing will happen, right? And we hear those stories all the time about whether it's hospitals with data, credit card companies with data. And so I think that the way that some of the digital health tools have overcome this security risk is by having patients sign an agreement that says, I'm signing a EULA and I agree that this data will be sent forth into the world or put into a larger pool where, something may happen to it. What I mean by that is fearing that we need the full capability of security and HIPAA and privacy and being fearful that no application will ever reach that, therefore we cannot use digital tools. I think that's pretty naive. And I do think that is exactly where many of my clinical colleagues, are still at. And the reason for that is because we're used to safeguarding patients' information. But the reality is we now know that even hospitals or health systems are not immune from that, and neither are health IT systems. So whether it's big or it's small, a capability does have to be there, that you demonstrate that the data transfer from the patient's smartphone to the doctor's office, for example, is secure. But that being said, there's a lot of other things we do on our smartphone that's encrypted and secure as well. The third capability that it has to have, most importantly, is it just has to be fun to use. I mean, there's a reason why people can intuitively figure out Instagram and Facebook. I don't know if the folks listening have ever tried to access healthcare on their phone or on their computer, even for their, I don't want to mention any specific vendors, so even their health IT application or their doctor's office. Healthcare sites and healthcare navigation tends to be very cumbersome and very complex and so different than our user experience that the design of your digital health tool, the user design, the interface, and just the ease of that is the key nugget that is going to make people want to use it. And I think that would be where people should focus. What was the second part?
Sure. His second part is what are some critical success factors, and then the last part is where have the greatest results been obtained today?
Yeah, I would say the success is in the design. And when I say design, I don't just mean, as you guys all know, I'm sure that are listening, I don't mean, I mean, it's just like a product design question, right? And it has to do from first knowing the problem you're solving and the steps the patient would have to take in order to solve that problem so that the digital tool matches it. And secondarily, where and how you literally place the icons with the colors. And to do that, you don't need any healthcare people. You need design people and software people working together. And I would say that just like any other online tool or web-based interface, having navigated this, it's a pretty clunky conversation initially to have software engineers who can just build amazing capability, talking with graphic designers or architectural designers or, web-based designers who say, well, it has to be beautiful. Like, we don't really care so much what it does, and bringing that together. The greatest success story.
Oh, did we lose you, Ayesha?
Yep. No? Can you hear me?
Sorry. Yep, now I can hear you.
Oh, weird. So I was going to say success stories. I think even though there are a few success stories that are out there in the consumer-based space, I would say that I've been marveling and surprised at the depth and degree that the insurers and the payers are starting to really pay and look at and look for impact on their chronic disease management. So if you talk about dollars saved or dollars spent, which has led to some change in the usage of the healthcare system, I actually think things like, Blue Cross Blue Shield or Aetna or Optum have done a very, very, very good job of starting to really think about this and have the dollars to spend on it and the large amounts of patients that are under them. That doesn't mean a consumer product can't be successful without the insurers or the payers, but if I was looking to then do something with my digital health tool and I had to choose a target customer to sell to, because in healthcare, the incentives of who you sell to are so different than who the user is often, I would pick the payer over the clinicians and the hospital. I think that if they are convinced, they then can have thousands of subscribers, if that makes sense.
Thank you. So we have a question that has come in from Nidhi Badaya, and the question is, within a health organization, who are the best stakeholders to engage first with regards to digital transformation?
So, that's a great question. The two-part conversation between the patient or the consumer and the trusted clinical entity, whatever that is. And in this day and age, it could be telemedicine, it could be your physician, it could be a nurse practitioner at a CVS Minute Clinic. I do think that one, if not both of those, have to have input. So I do see a lot of digital health tools that don't have enough of that and have to understand a little bit about the journey and the workflow, particularly if you can get one of those two parties to articulate for you their biggest pain point. And I mostly land on the side of the patient. So, we can use the child's inhaler example again. I mean, no kiddo is going to be able to write down or really tell their mom exactly how many times in the last month they've had to pull it out in gym class. And I think that does a few things, right? They're already nervous about pulling it out in gym class because they look sick and other kids might make fun. And so they might be reticent to begin with. And then on top of it, if they have to go and write something or record it or have to go into the nurse's office to document it and talk about it, then that becomes hard too. So that's the user pain point problem. The mom's worried, the pediatrician's worried, but the mom is the one really, really worried. So if you can solve it for mom and she doesn't feel like her child's asthma is just continuing to get worse, she'll pay. Either she'll pay, and if she doesn't pay, like she'll be interested. And then I think the reality in digital health is that tool has to show less ER visits for asthma, and then someone will pay. You'll either get an investment, you'll have a payer pay. But I think patients, more and more consumers pay for the things they want and the things that work. And I think we need to start tapping into that a lot more than sort of telling them what they need to be doing.
Okay, great. Thank you. We have a comment that's come in from Jill Christians, and she's saying digital health seems to add on, not replace live care. So it doesn't reduce costs and may even demand more time from clinicians. Do you agree?
I definitely, in its current state, I do think that so the first part, I'm not sure. I don't know. I can't really answer the cost question, but because I think that it's too early to tell, and I definitely think that there's a place and a way for it to reduce cost. I just think that the frustration that I'm hearing in that question is true, and that most tools haven't gotten there yet, and most of the integration into like workflow hasn't happened. And I don't think that's a clinician problem or a patient problem. I think that's a tool problem. I think it hasn't really thoughtfully thought enough about like what it is that the pain point is and how you integrate it. Let me give you an example. A clinician has to use an IT system. When you add into that, like logging into a phone or a separate site in order to use a tracking tool, it becomes really difficult for the clinician to find time. And that's where it adds time. And I've been there. And I do think that the adding of time is a real dilemma because we're so crunched to that 7 to 9 minutes per patient. So the reality is the adding time, I think that's absolutely true. The reducing or adding costs, I'm not sure. I feel like there's some tools that reduce cost. The majority of them don't. The majority of them don't necessarily add cost. But that being said, they have not bent that cost curve enough yet, and hopefully they will.
All right, thank you. I think we have time for a couple more questions. I've got one that's come in from Octavio Faria, and the question is, what about AI initiatives in healthcare?
Yeah, so great. So great to hear from Octavio. It's funny because I think there's quite a few supporters and friends who have logged in, so thank you. I think AI is brilliant. So we have this discussion a lot in Boston. I think with my limited knowledge, I've really come to think hard about where and how this could be useful. The triage process, for example, just calling around to figure out where and how and who to talk to, the AI component can become very helpful to be responsive and ask some questions. It's still clunky. Wondering whether we can get it to a place where people trust it is the key. And we'll have to see where that lands. So I think there's a big, big push for it, but we'll have to see like kind of where we can have it deliver. Now, that being said, companies like IBM Watson, companies like the insurance companies, they're all looking at tools. I think it would be wonderful to really implement a chat bot that can alleviate, again, let's use the mother with the ear infection concerns, to talk her through the process, through some prompts, maybe have her use some of the tools like SteTHOSCOPE, get the image sent off. I mean, that doesn't need a human being necessarily. We're just used to doing it that way, and the HR cost is really huge. So, okay.
All right, great. So let's do one more. We've got an interesting question that's come in from Kevin Chester, and his question is, can you speak about elder care, how the business model for elder care facilities might be disrupted by evolving technologies, and then how this affects elder care in rural areas?
Yeah, I think that just digital tools in general and the ability, I think elder care is just, the rural part's really interesting in that question, because rural care is very much based on access to care, and the access to care is very limited, and having digital tools that can transmit. So let's use like a stroke patient, for example, like an older patient that has a stroke. you kind of want to monitor things like either their gait, or are they doing okay, or just even their pulse. I mean, blood pressure is still a very difficult conundrum to measure. That is where the digital tools and the wearables can really come into play. Where we're struggling with that, I think across the board and in the world, is that it's really, really, really hard to convince people that they should wear things that sort of either demonstrate that they're sick or point out that they're sick or that they're being monitored. And so you've really got to appeal to, here's the feedback loop. Let's say somebody does wear it. You can suddenly, through some digital tools, have a phone conversation. I mean, just imagine FaceTime, really figure out whether that person's speech is still dysarthric, figure out from the utilization of their phone in their pocket and motion sensors or some attachment, whether their gait is happening and whether they're moving at all. And then have a secondary system where it prompts an alert if the patient hasn't moved in a few hours, and then that prompts a phone call from a family member or a clinician, and then you prompt a visit or like a paramedic or a nurse visit to the home. So elder care in a setting where access is limited and not in a big city and they're in their home, that's huge. That's going to be a huge area, and it's not just here, but other places such as Singapore are really interested in it as well.
Thank you, Ayesha. It's really fascinating to think about. We want to thank you again for such a timely and important discussion today. It's been such a pleasure to host this event, and I want to thank all of our Sloan alumni and friends for joining us. Please join our future MIT Sloan Alumni online events, which are made possible in part by the Sloan Annual Fund. As today's event comes to a close, we hope you'll just take a quick moment to complete the brief survey that will pop up on your screen. This will help us to continue to create programming that will be meaningful to you. So thank you so much for joining MIT Sloan Alumni Online.